Good evening, good evening, good evening. Welcome from my Facebook family and also my YouTube family to this very special broadcast entitled Mental Health with an emphasis on PTSD. And at this time, I would like to welcome my very special guest, therapist, Mr. Derell. And without further ado, I'm going
Thank
to.
you. Thank you.
You're welcome. Introduce yourself if you like.
Okay. Well, once again, I want to thank you once again for having me on. For those that don't know, can you hear me? You can hear me okay?
I can hear you. Yes, perfectly.
Okay. For those that don't know, my name is D. Derell Spears. You can call me D. Derell. You can call me, Derell. Some people just call me D. Whatever. I have been on YouTube for at least for almost 5 years. I am a licensed professional counselor. I repeat, I am a licensed professional counselor in the state of Texas. I have over 20 years experience in mental health. I've been licensed as a clinician for over 16 years, and I've been providing counseling services for almost, I would say, for 20 years in the field as far as being qualified to provide counseling services. So I'm originally from Louisiana. I went to an HBCU, Southern University. That's where I got my education in psychology and counseling. One of the reasons I got into the field is that I always wanted to help people, particularly help people in my community. I do like the fact that I have the privilege of doing so, and I've been providing help to my community for well over 20 years. I moved to the state of Texas in 2003 for more opportunities, which I was able to obtain. Became licensed here. I provided work for several companies that I worked with before I decided to start my own practice and to build my own facilities and so forth. I do have a company by the name of Transitional Life Counseling and Consultation. You can also check it out. I have a website, which is www.transitionallifecounselingandconsultation.com. I operate out of three different cities. I operate out of Houston, which is my mainly outpatient services and community oriented services. I operate in Dallas also. Actually, just recently relocated back to Dallas for one of my satellite locations, and my main office, which is in Galveston County, which is a suburb about 30-40 minutes outside of Houston, in which I focus on mental health as it relates to adults and children. We also provide day services. We also provide community services, community orientated services for kids in the schools, out of schools, alternative schools, case management services. I have several therapists that work for me and other professionals that provide various amounts of services. We service about 7 counties in the state of Texas. In those 3 locations, about 7 counties. And one thing that we have provided a lot of services for, which is the topic at hand, is PTSD. And I'm going to talk to you all about my experience treating people with PTSD. I began treating people with PTSD probably since about 2000. I want to say 2008. I may have had a few others that may have had it, but not as a primary illness. They had another illness that probably was seen as the primary. As I became further established in my business and so on, I began to see more of it as we began to be open to more people. And the majority of the clients that were diagnosed with PTSD were usually people who either worked in the criminal justice system or they worked in the military. And I'm going to talk further about the demographics as far as those that are going to be more at risk of being diagnosed, and the situations that come about that cause this type of illness. PTSD is a illness of circumstance. It is not a hereditary illness in which this is something you may develop because of heredity or socialization or behaviors. It's a result of circumstances in which you experience a certain level of trauma, which becomes recurrent because of the 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 issue that took place and the risk that it posed to you from a survival or from a life existing standpoint. So I'm going to go in line with that. Just kind of talking about my experience as it involves um, the facilities that I have and the type of clients that I see, and then also I'll dive into the statistics and the clinical work that's involved in that uh, as far as treating that population.
All right. Well, the first question I had is, what is mental health and the types of mental health?
Okay. Well, mental health is basically when we're talking about mental health as a field, as a field of study, as far as it relates to health, it involves anything that affects the way you think, the way you feel, the way you react to things, consciously, subconsciously, everything that involves you cognitively thinking to function throughout the world. Um, Mental health is something that affects um, how you view people, how you socialize. It affects how you um, have stable relationships. Okay. Now, also with mental health, there are certain types of illnesses that are hereditary that can be medically induced or substance abuse induced, or as in PTSD, it can be a traumatic event that induces that type of behavior. So, mental health in itself relates to all the different areas or specialties that I listed, but also the treatment of that. And the treatment of that can be done in a variety of ways, typically within the form um, of medical services, psychiatric treatment, psychology, and also counseling or therapeutic services, and also the assessment or the appraisal of the functionality of people who have different type of behavioral or psychological issues. So all of those things together involves or is a department related or interrelated to mental health.
Okay, that was an extensive answer. And from your perspective, why is the subject of mental health and all of the mental types of health that we have, why is it so taboo in our community?
Okay. The reason why mental health is so taboo in our community because mental health is something that did not esoterically develop all our community. The black community historically has always been suspicious of things that did not come out from our community that other communities pretty much establish and they bring to us. And so there's all types of examples as it relates to social welfare, as it relates to medical malpractice, as it regards to the criminal justice system, all different things that are outside of our community. And when we have been involved in those communities, we have suffered from racism and discrimination and violence and things of that sort, and mistreatment. There are tons of examples of African Americans being mistreated when it comes to the system. And so when the African American community uh, looks at those services and different areas of field as far as treatment, we tend to look at it with a great deal of skepticism because of our history of being mistreated when we participate or need those services. And so the African American community looks at mental health as being taboo because They look at it as something that white people do. These are the common phrases that are stated in our community, particularly when I am giving psychoeducation to try to encourage people that need it. Also, you look at it from a religious aspect. There's a large percentage of our community that feels that, religious wise is the best way to handle things through prayer and worship. Uh, and so those are usually the the type of phrases and responses that you'll get in our community when it relates to mental health. And also, more than anything, a lot of people in our community look at seeking mental health services as a sign of weakness. And so when you combine all of those things, it equals to a community that is um, very, very skeptical and very suspicious of mental health in itself, as far as the services, and particularly the people who carry out the treatment.
Okay, we have a question.
Sure, sure.
I was going to wait until afterwards, but I don't want to get too far and
Okay.
forget. But there's a question from Thug Life Manning. Salute to you, Thug Life Manning. And his question is, how do you feel about people that have a mental breakdown, a flashback that's been in the Army?
Well, that's actually symptoms of PTSD, and I will get into that. And so, what he's basically describing is symptoms of PTSD. And what I feel about it is that people who are experiencing that should get and should obtain mental health services. And untreated PTSD can be very harmful to yourself and to your family, because people who act in those ways have a tendency to also act out in violence or put themselves in situations where they can be harmed by others. And also, I want to keep in mind that a lot of situations that you've seen in which people act out and go into having a post-traumatic episode, a lot of police are ill-equipped to handle those type of situations, and sometimes a hyper-vigilant police will use aggressive or fatal means of trying to handle people who have mental illness, particularly of that sort. So I feel that in essence, it is a very severe mental illness that needs to be treated immediately, because it can have very harmful outcomes if not treated effectively.
Okay, so to backtrack, what is PTSD, which is the acronym for post-traumatic stress disorder?
Okay, so when we're looking at it as it is consistent with the DSM, there's about, I want to say that there's several features that outline as far as PTSD in itself. But I don't want to go be too technical with it, and I'm going to kind of explain it in a way that kind of focuses on the major aspects of it. And so when we're looking at PTSD, we're looking at a situation that involves you experiencing, witnessing a unwanted event or a traumatic situation, or the inability to avoid that situation, which or something that's somewhat intrusive in nature, in which it affects and causes some type of mental or physiological change in a person that's outside of the normal range. And so what I'm stating is that PTSD comes about when a person experiences an unwanted situation, whether it's a car wreck, warlike events, gunshots, let's say sexual assault or rape per se, things of that sort, near-death situations, whether it's a hurricane, a flood, near-death situations in which something is so intense that it continues to have a blueprint in one's mind. And in the event of that, it manifests itself if you have episodes within 6 months to a year after consistently after that event, which causes you to have anxiety attack, panic attacks, which causes you to have shortness of breath, sweating, fainting, uh, erratic speech, or sometimes you have a disassociation within the orientation of your environment, particularly when it comes to uh, uh, our military, in which when someone goes into a post-traumatic anxiety episode, they'll think they're in a warlike situation if they're triggered by seeing people that look like the people that they were actually fighting against, or an environment, sound, any type of external stimuli that triggers one to be in a different state of mind. And so also one of the more common symptoms is having nightmares or dreams that reflect that particular event that caused the stress. And so these things recurrently happen. And when you're looking at the diagnostic criteria, if those things are happening at least consistently for over 6 months to over a year, that could be signs that you have post-traumatic stress disorder. So what I basically did was kind of summarize from a diagnostic standpoint, and also experience examples of what that may look like, and that pretty much summarizes, paints a picture of what PTSD looks like.
Okay. The next question is more technical in a sense,
Sure.
but as far as statistics, what would you say for the past 5 years, the present, of the amount or numbers of people that have been positively diagnosed with PTSD?
Okay. Now, if you look at it from the overall standpoint, I'm going to say there's about 6 million people um, with PTSD diagnosed a year. There's a total, let's say, well, 6 million that are diagnosed on average every year. Usually, when you look at the total amount, I'm talking kids and adults. The totals may be like about 12 million adults. So the overall percentage, PTSD makes up about, I'm going to say, about 3.5 to about 4% of the population in the United States. So this depending on the research, you're going to see it range anywhere between 3.5 to 4, maybe even 5%. So it's going to be it's a small amount, but it's not so small when you look at as far as the overall treatment. But what we're missing, what the numbers don't tell you, is that there's also people who have this illness who are not diagnosed. So we can look at the technical research, but the research does not account for those who have PTSD who just refuse to seek the services and who are not being diagnosed. So also what the research indicates, particularly since the occurrence of COVID, there has been a rise in the diagnoses and the amount of people who have experienced this type of stress-related disorder, mainly because of the issues of different things that have happened because of a health scare, people staying extended amounts of time at home, or lack of social interaction. There have been events that have negatively came out of that has caused PTS related issues. But on average, we're looking at about 3 to 5% of the population diagnosed with this illness. But more importantly, I want to focus on the fact that when you look at the Black community in itself, 8% of the Black community is on record as being diagnosed with PTSD, which is the highest number as compared to other groups of people. When you look at the Hispanic community, it's like 7.4. I'm sorry, it's like 7.0 for Caucasian. It's 7.4, for the Asian community, it's the lowest, around maybe around 4%. So as in the African American community, um, I think that these statistics highly resonate with the issue of the previous question as far as how we view mental illness. And I think that there's a lot of Black people who have PTSD who are not getting the services, and also to the fact that because of environmental circumstances. And when I talk about environmental circumstances, I'm talking about the large percentage of African American people who live in violent neighborhoods and at-risk neighborhoods and so on, that become more at risk of being robbed, some type of violent situation, gunshots. We're more at risk, particularly in urban centers, of experiencing those things. And for many years, those types of symptoms, or people who had those experiences, were somewhat, I won't say ignored, but it was not assessed appropriately. But over the past 10 to 15 years, people are becoming more aware of the fact that the upbringing in those type of environments does have an effect. Also, the interaction with police can also trigger signs of PTSD. And I give you an example. If you've been in a community that is highly violent, has a lot of drug related issues going on, a lot of crime, and you've seen police brutality, you hear the sirens, you hear all different types of things, the gunshots and so forth. For other communities, hearing the sound of police sirens is a sign of relief. But to the African American community, that's a portion of our community who actually are triggered. It actually triggers anxiety when they hear that, because many people that see police in our experience and from our perspective look at it as a negative event, or a negative outcome is about to occur and someone's life is at risk. And so in the field, we've grown to correct the misdiagnosis or the lack of understanding how culturally PTSD may apply differently to other groups, particularly when it comes to the African American community.
Okay, I have a few comments and questions I would like
Sure.
to have addressed before we go further. One is from Miss Andrea. Good evening, Andrea, and thank you for coming. Mods, thank you. And if you don't mind, please make sure you post the links in there. Andrea asked, why does some doctors just say bipolar, not giving a full assessment for better education, understanding, for humbling oneself? And let me know if you need me to reread that. Or are you able to?
I want to clarify. She said, why do some doctors just say bipolar?
Yes, and not giving full assessment for better education, understanding, for humbling oneself.
Okay. Unfortunately, I'm trying to figure out the context, because from my experience, doctors don't usually just say that. I've never had a doctor that talked about that particular disorder. Even it's not related to the illness that we're talking about, but whether it's that illness or another illness, if a mental health professional is talking about or speaking on a diagnosis, they should give some type of clarity and talk in detail about how that illness presents itself. I don't know if that's something that person experienced or they've seen that or whatever, but from my clinical experience, when we speak of illnesses, particularly psychiatrists, psychologists, counselors, social workers, we give context. And if you want to speak on bipolar, there's different types of bipolar. There's bipolar 1 disorder, there's bipolar 2 disorder. And then also, when you have a diagnosis of bipolar, it also focuses on your mood, the most recent mood, and whether or not you have psychotic symptoms or don't have psychotic symptoms. So it's bipolar is just not simply bipolar. There's also other features that may also accompany bipolar disorder. I hope I
Okay,
answered that question. But but that's And speaking of that, you typically are to give some context on that.
absolutely. Monica had a comment, and it's something that we spoke on briefly and will elaborate further. But cranial sacral therapy, and she puts in quotes or parentheses, alternative healing is good to add with therapy for one that suffers PTSD too. Now,
Cranium therapy.
cranial sacral therapy. I'm not sure if I'm pronouncing that
Okay,
correctly.
I am not familiar with that. I have no expertise, so I can't really comment on that per se. I would have to do my research on that. But my training never involved that type of therapy or anything. So I don't know what that means per se. But what I can say is this. I do agree that there are other forms of holistic therapies that in operating parallel to therapy are beneficial. So if it works, I mean, I've seen people use various type of spiritual activities that can also operate in parallel very well with mental health. I actually encourage those who meditate, who use prayer, who use whatever type of spirituality that they have to also be a sort of coping mechanism for their mental illness, running in conjunction with mental health services, professional mental health services.
Okay, yes, that's something that we can elaborate on later because I had a question about types of healing as well. The next one we had, and you touched on it already. Why do doctors keep trying to give out pills?
Okay. Why do doctors keep trying to give out pills?
I don't want
Now,
to say dollar
for,
signs,
for,
but you're the
for my, oh, go ahead. I'm sorry.
you're the expert in this, so go ahead and give
Okay.
your own perspective.
Okay. My perspective is this. Um, it depends on what school of thought you come from. Now, I was trained because I was clinically trained and I went to an HBCU. I didn't go to a PWI. So when in going to an HBCU, we do tend to train on the basis of helping our community, which I think is appropriate. So when I was trained, and I did have psychologists who did train me, and I did internships, we used the term intervention, then medicate, intervention, medicate. So what that means is that we're going to try to minimize or reduce the need for medication if possible. Okay. Unfortunately, when you look at things from more of a medical model and other different models, they may think different. So it all depends on the school of thought of the profession. I do agree. I'm not going to say I'm going to discount the use of medication, but I do agree with the minimization of medication and only prescribing those medications when it is warranted. However, if you are diagnosed with a severe mental health illness and your level of function has decompensated to a point where you cannot function, I have and I will refer out to a psychiatrist to provide those services for you, particularly if you're decompensating or you're at risk of harming yourself or somebody else. So I want to caution us as a community of being, it's not necessarily of being negative towards the prescriptions of medications, but to only look at it on an as needed basis or when it is actually needed, not necessarily out of convenience. And I think that the medication aspect of mental health is one of the reasons that our community is so suspicious and anxious about getting those services, because there are many situations in which medications are pushed upon our community. So I do understand any as far as the perception of that and feelings towards that, and how that may affect how you think of mental health, I think that's something that needs more work and communication. So I do understand it, but from my perception, I'm about intervention and medication as needed, as the last resort.
Okay, and Monica piggybacked off that and said that it's the FDA that's pushing it. And I wanted you, if you would please, clarify the difference between a psychologist and a psychiatrist.
Okay. Okay. So those are the two highest levels of mental health as far as people who operate at the highest level. And the difference between a psychiatrist and a psychologist is that a psychiatrist has to go to medical school, and psychiatry is a medical specialty. Psychiatrists can also be medical doctors, an MD. You can be an MD and a psychiatrist. Most psychiatrists that I know, most of them are actually MDs also. So they went to medical school. They have they're actually a medical doctor, and they also have their specialty in psychiatry. There are some psychiatrists who are not MDs. They strictly just went straight into the specialty itself. Now, what makes it different from the psychologist is that the psychologist is more trained in statistical knowledge, assessments, psychological theory, okay, and things of that sort. The psychologist is actually the hallmark, or I would say epitomizes what goes on in the field, because the psychologist does all of the field research. They do all the analysis, the assessments. They have a huge influence in the DSM, the diagnostic manual of statistical manual. Psychiatrists are also involved too, but the psychologist is more trained in more things that involve the intervention with the client. The psychiatrist in itself looks at it more from a medical standpoint. They're all equally as trained as far as diagnoses, but the psychologist is going to use testing and assessment and inventories to come to a conclusion, as opposed to a psychiatrist who's going to strictly use their clinical knowledge from the DSM and their observation to come to their medical conclusion. So those are the overall. Now, psychiatrists can take extra courses and things. There are several, not a lot. The minority. There's a small percentage of psychiatrists who actually provide therapy. Most of them don't. But there are the ones that are at the top level of the field. Some of them are psychoanalysts. Some of them learn certain therapies and so forth, and they specialize in those different things. So those are the differences. It's a matter of skill level, and the skill level. What separates the psychologist is that the psychologist is more treatment orientated as it relates to assessment of the as far as presenting battery of testing, assessment, and the theory itself as far as the therapeutic interventions. A psychiatrist is more in line with just diagnosing you and treating you with medicines. Because see, a psychologist cannot prescribe medication. So those are the primary differences.
Absolutely. So you touched on this earlier, but I'm going to piggyback and rephrase it, so to speak. In your perspective, as a licensed clinician, what are the main triggers, and does one feel an onset of a trigger like some do with anxiety attacks? Like, for instance, some that experience anxiety or have been diagnosed with anxiety may feel certain symptoms coming on before a full-blown attack. So someone that has PTSD or someone that's been positively diagnosed with PTSD, do they experience anything before it comes on, or does it just come on just like that?
Okay. Now, I want to, because it was a loaded question, I want to make sure that I decipher every aspect because from what I was hearing from it, everything pretty much integrates, it's interrelated. So could you read the first part of that question again so I can make sure I can kind of go from each go by piece?
Sure. What are the main triggers of PTSD?
Okay.
And okay, and the second part, I'll ask this the next later. The second part was, and does one feel an onset of a trigger, or does it just happen?
Okay. Um, the triggers of PTSD are different per person. The triggers are contingent upon the event that caused the PTSD reaction. PTSD is a stress related disorder, meaning that you are involved in a situation that caused the stress, that causes the anxiety. Okay? And PTSD is also interrelated with anxiety because people who have PTSD also suffer from panic attacks and other anxiety episodes because they're in fear of because of the situation that caused a near death or a traumatic event. So what I'm going to say is I can't give you an example because it's different for everybody. What triggers PTSD for one person may not be for the other. It's all to me um, um, it's all circumstantial towards the event that they experience. But what I can say is this: anything in your external environment that reminds you of the situation that you experience is a trigger. For instance, if you were like several of my military guys that been to the Middle East, Afghanistan, Iraq, Iran, when they see Arabic people, that can be a trigger. Now, for somebody else that has PTSD, that may not be a trigger for them if they have not had that experience. Gunshots, loud noises, any type of yelling, screaming, anything that reminds them or put them in a situation where they think they're in a warlike situation, that's their trigger. Now, let's go with a person who went through a hurricane and lost their house, and they were swimming in water before they found and was able to find refuge barely at a time out of desperation to survive. Well, a person like that, PTS triggers could be the mere sound of thunder and lightning, seeing water on the street, and things of that sort, gusting winds, or that a lot of heavy winds, things of anything that's a severe weather issue can trigger PTSD. Now, again, the situations are different, but when we group and departmentalize, it's all sensory related or stimuli related to what you see, what you feel, what you smell and touch, or what you experience. And it's all relative to that activating event. The activating event is the initial event or the occurrence of multiple events that cause you to continue to relive or be fearful of that event occurring again. So those are the triggers. The triggers can vary. It's all about what the event is and what you experience that can in any way dictate what you're going to be fearful of or have issues coping with. The second half of it, what's the second? It was about anxiety. Was it anxiety or something? Or
Yes, I wanted to know, and you actually answered it for the most part. I noticed that you said that they intertwine, so to speak. So
yes,
my question,
anxiety and post traumatic stress disorder intertwine because um, in stress related in any stress related illness, there is a level of stress causes anxiety. Stress is actually a trigger of anxiety. So they're interrelated. So when a person who has a post-traumatic or stress-related episode, they are going to exhibit anxiety related symptoms such as shortness of breath, heart pounding, sweating, problems with orientation, shortness of breath, or deep or lack of breathing appropriately, slurred speech, or flighty, loud speech, things of that sort. So those are all it's all interrelated.
So does one that has been already diagnosed with PTSD, will they feel that coming on, or could they just be going about their regular normal day and an attack will just come on? Or do they need to have those stressors that you mentioned earlier, a sight of an individual or something that may take
Right.
them back to a particular time?
It's actually all of the above. In this situation, it all depends on the person. There's some people who can be going on by their day and they can feel it coming. And I'm going to talk about the process of what that looks like. Then you have those who are triggered by something that can cause it. It can either come about subtly or it can come about spontaneously. Now, part of what I do a lot in therapy, and I don't want to, I know you haven't asked a treatment related question, but treatment wise, we work on identifying triggers. We work on what the warning signs may be for a person. And so when we talk about it coming about slowly, usually a client who has PTSD will verbalize that they're starting to feel nervous, they're starting to shake, they're starting to sweat, they're starting to have flighty, constant thoughts. They're starting to feel like the room is closing in. They start having physiological changes. That's how most people verbalize that they sense it coming. Then you have people who will state, like I've had situations where a client said they were just going about their day and they were just all of a sudden, and bam, it just happened. The thought came about and they went into an episode. So, in the treatment aspect of it, regardless of if it comes in a subtle, gradual process, or if it comes just from spontaneously out the blue, there are counseling related techniques and coping mechanisms that we can use to treat it, even if it happened either way. So the answer is it can either be for any individual, it could be one or the other, or it could be both. It's not a one size fits all scenario.
Okay. So when that attack with the walls coming in or those symptoms, what should one do to get to a safe place mentally? In other words, where could one, or where does one go to seek refuge during that time of this attack?
Okay. Now, there's two ways you can look at it. But strategically, I would look at it differently if you're out in public, or you're somewhere inside of your home, or if you're somewhere outside of your home. Okay. Now, in many cases, for someone that has PTSD, they usually experience PTSD outside the home. Some may do it inside, but usually when they're out, when they're like outside in the community. So what we want to do is that, and this again, I used my school because I know you had a question that was kind of looking at the interventions. I'm from the school of thought that focuses on what is called cognitive behavioral therapy. Cognitive meaning thought process, behavior meaning what you exhibit, and so forth and so on. So I utilize cognitive behavioral therapy. In cognitive behavioral therapy, the focus is to identify your thoughts, your feelings, and then the behavior. So I'm going to ask a person to start internally questioning what's going on, asking themselves, what are they experiencing? We learn what we call internal thought processing, in which you start asking yourself, am I getting nervous, or am I starting to shake? Am I starting to this? You start, not externally, but non-verbally telling yourself in your mind, are you noticing the changes? And so what we want to do is use positive self-talk. We want to use soothing mechanisms to ease and relax. And in that, to me, the best ways to alleviate post-traumatic stress episodes is relaxing one's muscles and deep breathing, and doing that repetitively, slowly, but consistently, and easing yourself, and to go into an environment where you're away from whatever you think may have triggered the episode. So, for example, if let's say you're in a mall and you're shopping, and then you notice yourself having the episode is coming. In that situation, from an intervention standpoint, I'm going to use what's called behavioral shaping or behavioral instruction methods of giving instruction of how, once you identify that something is changing, you instruct yourself to deep breathe, diaphragmic breathing, and things of that sort, but to also leave that situation and isolate yourself to be alone, whether it's in the bathroom, in the corner, in the hallway, somewhere where you're away from everybody, and concentrate on using progressive muscle relaxation, deep breathing, mind soothing thoughts to coach yourself to relax. And you're using these things symptomatically. When you're at home, I would be more open if you overtly say, how you're feeling, but you can also be internally, whether people are there or not, but also go into what you consider a safe place for you. For most people, the safe place is either going to be their room or the bathroom. And you either go to your room or the bathroom and you start deep breathing and muscle relaxation, or even meditating and things of that sort, to calm yourself and soothe yourself of the anxiety that you're experiencing. In many instances, when I do that, most clients tell me within 5 to 10 minutes they can minimize their stress by repetitively using techniques to soothe themselves.
Now, when you go through these attacks, or those that you are aware of, is it possible that sometimes when you're going through something that you forget these techniques when you're going through the storm, so to speak? And if so, how long does it take for you to not snap back, but how long do you think that it would take for your mind to get you to that place where, okay, breathe.
Right. So it all depends on, to me, it's not about, I'm going to say this, most clients don't forget. If you're consistently getting therapy, you're not going to forget how to use it. What happens is that it's the severity of the episode. If the episode is so severe where you just it overwhelms you that you're unable to apply those strategies, that's usually the case. If you're consistently going through therapy, you should be able to, because that's part of the therapeutic process, is that we're learning, we're focusing on you retaining the methods that are being taught. Now, I'm gonna say this: there could be most situations where the client forgets to use or they don't use it. It's because the episode was so powerful or overwhelming that they felt helpless. Okay. Now, in the event that somebody feels helpless, and they cannot calm themselves down, I usually encourage that person to leave whatever situation that they're at, that they experience it, to go to a different scene, like whether to go outside, get some fresh air. Again, I usually like to use, for most of my clients, my experience is going into your room, going to the bathroom is usually the safe spots that most of my clients find effective. So it's about, say for instance, wherever you're at, one of the most effective ways of alleviating the stress is to leave where you're at and go somewhere different. And if things are getting so out of control, if you have a family, a friend, or someone, I would encourage them to call 911. There may be a possible hospitalization that may be needed if you're unable, or you're overwhelmed where you can't function. So those are usually options. So there are times that will happen where you're overwhelmed and you don't remember. You just can't, because it's too much. And so when it becomes too much, I encourage to leave that situation to go to a different scenery, a different room, or somewhere where everything is different. It's not good to stay in the place where the anxiety stems from. You want to leave and go somewhere different. Again, all of this, the major part of this is to create a process of which you're thinking about doing other things and not just focusing on the fact that you're having an anxiety attack, or you're going through this situation. But to process your mind, to have you thinking of alternative ways to do things. And once your mind starts thinking about alternative things, you're not so focused on the event itself. You're thinking of other ways. And also, you got to also keep in mind, and we could talk about this, particularly family support can be very, very beneficial. Having a family member you can call, a friend you can call, or another mental health professional where this is more of a crisis situation, that which they can come in and help you alleviate the situation. So this cannot merely be relegated to you doing it, but also you can have a communal effort. You can have other people who are supporting you when it gets to that point.
So when you're going through an attack or a trigger,
Mm-hmm.
and let me do this diplomatically the best way that I can. And I understand that each individual, as you stated earlier, is different. Is
Mm-hmm.
it common, or again, does it depend on the individual that if they are upset or bothered by something or triggered? I believe that's the word a lot of people use when it comes to PTSD or anxiety as well, because
Mm-hmm.
there are things, as you mentioned, that can trigger anxiety. Do they just retreat, like you say, or do they let people know that they're triggered?
Most people, they're going to let you know that they're triggered, but a person can observe it. It's different for everybody. Some like it, to me, this goes more into the psychoeducation of the family to understand what PTSD is, and to educate people to understand, because a lot of times when a person is getting ready to experience the episode, they're usually quiet. They usually are quiet, and they don't, and they're in a space in which they are somewhat distant from let's just say you're sitting at home and you're hanging out with family. Everybody's talking, they're doing whatever, and then they notice you're kind of like out to yourself, like you're in a different space and you're quiet. And that's, people can observe that. We can observe that. And so most clients that I know, we develop the tools to communicate, to say, hey, I'm not feeling good. I think I'm having an anxiety attack. They're usually, now some people have difficulties communicating that. That's something you learn in therapy. as far as how to communicate your symptoms or communicate when an episode is occurring. So it all depends on the person. But what I will say is that um when an episode happens, there will be a change in your temperament, your mood, and your behavioral presentation. You're not going to have an episode and remain calm and relaxed. People going if people are mindful of you and know your baseline behavior, they're going to notice something different. You know, if a person gets PTSD in public, the people around are going to notice this person is moving or presenting or saying things that are out of a normal range. So it can easily be observable. You're not going to behave. Can you hear me? Hello?
Yes, I can hear you quite
Okay,
well.
okay. You're not going to behave, and your body language and things. It's not going to be the same as if you wasn't having an episode, and if you did have an episode. That you're going to see significant changes.
Okay, this is kind of
Hmm.
geared towards me a little bit.
Okay.
Um, I have anxiety, and it's born off of my medical condition, which
Okay. So
is
it's medically induced.
it was over the years. It's something that I've been dealing with for 30 years.
Okay.
And I know absolutely, and I'm going to say that again, I know absolutely when I am about to experience an attack.
Okay.
And it's medically related, but I personally do not announce it. I'm retreating. And
Okay. When you say retreating where?
if I'm in public, um, if I'm in a store, if I'm in if I'm at a venue, I'm going away from people.
Okay.
You will
Good. Good.
smell tire tracks. But that's just me. So is that again an individualized thing? I don't. That's something.
Now, I'm gonna say this now. I don't. I would not, and I'm gonna tell you this. I do. I do like the fact that you can identify your triggers. I would not. I would not encourage you to drive while having an. Because you say you smelling tire. I don't know. Are you rushing home?
Yes. When I think
Yeah.
when I feel that coming on, yes,
I wouldn't.
absolutely.
I wouldn't encourage you to drive while having that. What I would encourage you to do, if you're calm enough, first then drive. But but if you're able to handle it, I mean, obviously you've been doing it. If it's working, it ain't broke. It doesn't fix it. But to me personally, if I was treating you, I would not encourage you to drive while having, or to try to. Man, I would encourage you to. We would start focusing on you calming yourself down before driving. I would focus more on you bringing yourself down, easing that anxiety, and then driving. That's what I would do. But if you're at a point where you're able to do it, and I get what you're doing because you're able to consciously understand when it's happening. So you're gonna leave and go back and go home and deal with it at home, which is better to be in your safe spot. So that is good. But I'm going to encourage you for future references to maybe focus on just a little bit, maybe 5 minutes or so to and I don't know, like what we call grounding. Grounding is in a way of you managing and kind of controlling it a little, not necessarily controlling it, but you're trying to basically alleviate it systematically from one level down to another level before you get into a vehicle. I would not encourage someone to drive in the midst of about to have a panic attack or an anxiety attack. because that can affect your driving, your concentration, and things of that sort. So I don't know the level and the severity of it. It also deals with what your severity is too. I don't know how severe the anxiety. If the anxiety is not that severe, or if it's at a low level, you may be able to handle that. But I would encourage you to incorporate that a little bit. I know what was working for you, but I would, a competent therapist would not um um encourage someone to drive in the midst of preventing anxiety attack or to minimize it. We would want you to be at a certain level first before you get behind the wheel.
Absolutely. And that is
Right.
what my question was.
Yeah.
Again, these happen during, like if I'm having a major coughing episode and it may feel like, oh my God, I can't catch my breath, then that's when it will begin. So, of
Wow.
course,
Okay.
to me, that is something that I'm not going to announce to everyone. Like, oh my
Right.
God, is this it? Is this my inevitable happening now? I retreat. So what I'm saying is, I don't just announce it. Oh, I'm triggered, or I'm having this. No, I'm
I,
gone.
I, I, I would encourage you not to announce it to people that are not close to you that wouldn't understand. Like, I understand you not announcing it. And I actually encourage particularly clients that if you're not with your family or close friends, we try to deal with it internally. And the only time I would encourage you to announce it if you are overwhelmed and you're unable to control it. But if you're unable to control it or you can manage it, then yeah, there are proven ways um to minimize the severity of that attack. So that's reasonable. There's nothing wrong with that.
And finally, in reference to my anxiety, it's not so much of the attack itself, it's the symptoms, because on top of everything else, as you said, it feels like the walls are closing in, or and these are things that I experienced early on, and thank God over the years I've learned how to minimize them. But there were times where I mean, I'm laughing now because
Hmm.
it's the truth. I kid you not. But you would actually feel the tingles in your face, um,
Yes.
the jitters. And there was one time at work, and it is somewhat embarrassing, but I mean, this is something again that I mentioned to you earlier. I'm very transparent, and this is something that I feel. I don't know about anyone else, that our community really needs to talk about and kind of get away from this taboo and the stigma, because it's real. It's real. I was afraid for a long time because the first thing someone is quick to say is, you're crazy, or this, that, and the third, when most people with particular issues are extremely intelligent. It has nothing to do with your intellect, it is
No,
something
it
to
doesn't.
with issues that cause some type of trauma. But I remember going to the doctor at one time, and my pressure was elevated. My pressure is never elevated, even when I was at my heaviest of weight. And my doctor was like, something doesn't seem right. So I went through a battery of tests. So she was so sweet, and she gave me a portable blood pressure. Um,
Hmm.
what do you call it? A portable blood pressure monitor.
Right. Right.
Do not. I would be at my desk when nobody was looking, and I would take my pressure
Yeah.
every
And that's a sign. That's nothing wrong with
every
that. That's
five,
good.
every 5 or 10 minutes. I did it one time until my pressure was almost
Well,
180.
that was excessive, but I but
I
I
did it
get.
to myself
Yeah.
though, and I didn't know it. So I end up calling GW, which is in DC. And they took me to the hospital, and I think maybe 10 minutes later, after I calmed down, they were like, what happened? I said, I don't know. I kept taking my pressure and it kept going up. So the EMS said, well, how many times did you take it? And I said, about 5. He was like, ma'am, do you realize that your pressure will fluctuate? But if you are already nervous and each
Yeah.
time you take it, your reading is going to be higher.
Hmm.
And they said, do us. And he said it nicely, but I could tell in his voice, he was like, see, you're not going to drive us off
Right.
either. But he said, do us and do yourself a favor. Do not continuously take your pressure like that. And a nurse, she was so sweet, said to me, you do not have high blood pressure. Your pressure is elevated when your anxiety is
It's up. Yeah.
elevated.
Yeah.
And once I did that, I didn't have a problem again. But yeah, I had to hide my machine.
Yeah. So that you wouldn't engage in that. And the thing
Yes,
about it, yeah, you do understand when you have anxiety, you're not thinking at the same level. You can be a little bit impulsive, and it can cause some level of irrationality and impulsiveness because you're trying to do whatever you think can reduce the symptoms. So you're willing to try anything, you know. But and also you gotta understand when you're in that state, you're in a heightened state. And so when human beings are in a heightened state, we don't always make the same decisions if it wasn't in a heightened state. So, that's kind of how that works. It's okay. It's a learning experience per se.
absolutely. And that is why I stated, and hopefully, when this broadcast is over, people that might be suffering in silence, because I did for a long time. And again, it's medically related, but those are things that I actually did and hid it from people. And actually, because of the stigma, if you will, made my situation worse by not saying anything.
Yeah, long term. Yeah, long. Because see, and this is something that I encourage the community is that it's nothing wrong with getting help and those around you helping you through the process because the support makes it easier for you, you know, to do things. It makes it easier. And having that support can make a big difference. It can make a huge difference.
Now, for those without the support, do you have or had you had any clients that did not have a reliable support system? And for those, if you do or did have any clients like that, what would be your suggestion to them?
Okay, for the clients um who don't have like consistent family or friends, usually, unfortunately, um, I would encourage you to seek government assistance or government um, agencies that can help you. There's so many different. I mean, every state is different. But if you're a person who doesn't have any help, there are tons of support groups and organizations within mental health. Um, every state may have like a NAMI or a mental health association. They have some type of community orientated uh, services and so on where you can have access to people who can come in and whether it's crisis related case management, those type of services that are available. You should have a listing of available mental health services that can assist you in a time of need. If you don't have other family members who can provide that, so you should have a crisis hotline number. You should know the number to your local mental health authority. Um, you know, things of that sort. Then there's also, which most cities have, particularly larger cities, there's support groups. Um, I know there's a lot of there. I know of several PTSD support groups. Now, a lot of the support groups that I know of, a lot of them are typically VA orientated, which through the VA. Some are not, but most of them are through the VA because they know that a large percentage of military persons end up developing PTSD. But also, there are other communities who basically want to look out, and some people have just a love based on their own experiences or just things like that, people who have those type of issues, and they're willing to provide some type of support. And that support is to do check up on you. Even there are several police agencies that have a mental health component department. I know, like in the state of Texas, we have what's called MCOT or mental health deputies. All of those can be of your assistance, particularly on an as needed basis. But they are available to you.
Absolutely. I had mentioned to you about my work as far as the VA is concerned, and we'll get into that later. But my next question is, from your perspective, what are the activities that one diagnosed with PTSD should avoid, if at all possible?
You said the type of activity they should avoid?
If at all possible, if affected by PTSD.
The type of activities they should avoid are activities that can trigger the symptoms. And what I mean by that is this. Let me give you an example. If you're a person who has PTSD due to violent means, you shouldn't be playing video games that are violent. Okay? You shouldn't be playing video games that have the games like Grand Theft Auto, and where people are fighting and hitting one another and stuff like that, or it's extremely violent. Those are not the games you should be playing, because those games are triggering. Also, any type of, if you were in the military, you wouldn't want to play those games, nor should you want to play any warlike kind of games that kind of can put you in that mind frame. Also, if you are a person who developed PTSD through domestic violence, which to me is one of the larger, more growing populations, as far as particularly women who develop PTSD due to domestic violence, or children, you shouldn't be watching movies or any type of social media movies that displays that kind of behavior. Those are triggering. So I can't say it's not going to be relegated to one event or not, but to basically not engage in behaviors that were somewhat similar to the event that caused you to have the anxiety, that level of anxiety and stress. Anything that's similar to that, that's what you should avoid. You don't want to put yourself in environments or situations that are similar to the triggers or similar to the events, because that puts you at high risk of thinking of that. If you're a person that who've been diagnosed due to the weather or something like that, you don't want to be a person that's volunteering to save people that are in floods and are swimming and things of that sort, or being out in jobs or activities where you're doing this at night. I mean, doing it when the weather's really bad. Those are to me self-defeating behaviors. So I'm not going to say you can't do activities, but what I'm going to say is that don't do activities that are similar to or have conditions that remind you of the activating event that caused that traumatic situation.
So in other words, say someone witnessed a horrible accident,
Right.
and that accident scene is en route to your home. However, there are other means or other detours you can take to get to your home. Would
Right.
you
Right.
say that is that the same in what you're saying? If you already know that particular area, that scene that you saw traumatized you, would you, or is it safe for me to say that you would recommend not to keep going that route because you know already
Yes.
how it makes you feel? And would you take a detour, even though that detour may inconvenience you, but it could very well likely avoid a trigger?
I wholeheartedly agree with that. Short term. Now, long term, particularly in therapy, I would do what we call flooding exercises, in which we slowly and systematically acclimate a person to confronting that event in a way in which they can slowly become more at ease in operating under those circumstances. Say, for instance, in flooding exercises, we're therapeutically putting you in a similar event, but we're doing it in a process. So, and I've actually, it's funny you brought that up because I've actually um, done several situations where people were involved in wrecks, and I actually, it was actually more severe than they couldn't drive at all. They were afraid to get back on the wheel. So I had to systematically, slowly acclimate them to driving on the highway. The mere fact of driving or even thinking about driving uh, caused anxiety. So what I did was we would arrange for them to drive, but drive at a very slow pace. First, we'd start out in the parking lot, then maybe a neighborhood, like say their neighborhood or an area where they're familiar with, low traffic and things like that. We're going at low speeds and familiar places. Then we start going to like where we're, somewhere a couple of blocks or more, and then we gradually, slowly, through behavioral approximations, which is behavioral shaping, we're helping shaping a person systematically to slowly driving more and more and more till they get to a certain comfort level. That could take months, depending on the person and how they respond to the therapy. But I do want to say, when you're doing flooding exercises, you have to do it with great caution and you have to have patience. And it's a slow and steady process. It's a
Now,
slow process.
are you saying flooding as in FLOODING?
Yes, we call it flooding. Flooding meaning, and when we say the term flooding, we're meaning that we're exposing you therapeutically to an event that you can't cope with. So we're putting you so the very event that you have anxiety about, which we're therapeutically putting you in that event, but in a place in which we have some level of emotional control. Like, I'm not going to exert you full fledged into it, but I'm going to slowly, gradually put you into it at your comfort level.
Okay.
Yeah, it's not a like initial, like we just bam. We're just gonna put you in front of the wheel, and you're just gonna go. No. We're gonna slowly, steadily, but we call it flooding. Flooding. It's those are flooding interventions.
Okay, that's excellent. All right, you mentioned earlier, but I'll ask again for everyone that may be just coming in. And again, thank you for those that have come in from both Facebook and YouTube, and welcome our guest therapist, Mr. D. Derell. I put his link in the chat, so please make sure you go and subscribe to, again, Mr. D. Derell. So my next question, sir, is, you mentioned it earlier, but can you elaborate a little bit more as to what is needed for a positive diagnosis for PTSD?
What is needed for a positive diagnosis?
Yes, sir.
When you mean positive, you mean like a correct, a legitimate diagnosis of PTSD?
Yes. Yes.
Okay. Well, again, it depends on the school of thought. What I would encourage is that if you are, this is, well, I can go about it in the way I do it, but I can also just say, just systematically done or professionally done. The first thing that should be done to get a positive or a legitimate diagnosis of PTSD is to do what's called a psychosocial assessment or a mental health history assessment. And what that does is that we're asking questions, and we're getting an overall inventory of everything you have experienced, including the presenting event and how it has affected you. Okay, that history in itself will allow the client to go into detail on everything they've experienced, and so we can find out through that if it's like, say for instance, your anxiety is medically induced. There are situations in which I have diagnosed people based on the fact that some of these things were medically induced, or they had a medical issue, or they had a drug issue, or some other outside influencer to why they have this particular behavior. The other things that you also can do in conjunction to the psychosocial assessment is do a mental status exam. And in the mental health status exam, we're looking at how you presently feel at the time of you coming to the appointment. And in many situations, a lot of clients that have anxiety or PTSD, they're usually nervous, particularly if they're in an unfamiliar situation. They're usually nervous just doing the exam itself or undergoing the process. The next thing that I would talk about is that I would implement anxiety-orientated scales or assessments that in many ways evaluate how anxious you are today. Particularly when we're talking about PTSD, it also has what's called a differential diagnosis, in which there are also symptoms that are similar to other illnesses, that we may also use other mood-related or depression or mania-related assessments. So we're going to do some assessments, and we're going to evaluate the intensity or the level of anxiety that you have, and compiling all of that information based on the scores. And then also we're utilizing the DSM, which gives us the criteria that we have to follow. With that all together, we can come up with a positive, or what we say, a legitimate diagnosis.
Okay, and after that diagnosis is obtained, can you hear me?
Yeah, go ahead, I can hear you.
Okay, after that diagnosis is obtained, what is the very next step, or does it depend on the individual?
Well, everything depends on the individual. They have consumer choice, so they can decline or they could accept whatever services that I would prefer that they would do. So after they finish the assessment phase, we can either these are the treatment. This is a treatment, and in many situations, particularly if a person is diagnosed with PTSD, I'm going to refer that they seek a psychiatrist for medication, particularly adults, because I understand the spontaneity of PTSD because it can happen at any time, any place, and um, research has shown the high effectiveness of medication along with counseling or therapy. It has been proven to be the most effective form of treatment when you're receiving therapy along with medication. It's highly effective. So I'm going to first ask the client, are you receptive to medication, to getting medication? Some say no, some say yes. Most say yes. There's some that are going to say no. So at that point, once that has been established, we will go about creating a treatment plan, and from the treatment plan, we'll start therapy. Right? We'll start creating treatment goals. The treatment goals will reflect the issues or the areas that the client is weak in, and we're going to try to help them improve and function on those weaknesses. And then from that point on, we'll start therapy to start tackling those goals.
Excellent. Now, here's where I'm not so strong in the question and answer portion, but I think you'll drive it home, and that is who can be affected with PTSD as far as demographics. Now, you mentioned that earlier, but I don't
Hmm.
think many people heard it at first. And this is collectively as a community. And what you told me, I'm actually startled. So if you can relay that again, the actual demographics.
Okay. Well, we're
And
looking
it
at the
might be,
demographic. Oh, go ahead.
yes,
I'm sorry.
well, I was saying it may be hard for some people out here. It's not gender specific. However, from what I learned from you, it's a little bit startling. So if you can bring it home,
Okay. So when
raw.
we're looking at who's been more at risk, who the demographics show that when we look at it from the basis of race and gender, we're looking at black men as being the most at risk, particularly the black community, which 8% of the African American community has PTSD or have been diagnosed at some point in their life. We also look at the fact that when we draw the numbers down to other groups, the Latin American community is around 7%, white or Caucasian, non-Hispanics, Caucasians, it's 7%, and Asian community 4%. Asian community represents the lowest. PTSD is usually mostly diagnosed in men as opposed to women, and particularly because uh, the overwhelming majority of people who experience PTSD, as far as those that have been diagnosed, usually come from the military or some type of criminal justice related field in which violence is actually it's a violent, I would say a violent field in itself, or area to work in. Now, there's a high level of undiagnosed people also, but being that we're looking at research, we can only talk about those that are on record. So we're looking at the African American as far as percentage wise. We have a higher level, a 1% higher level of this particular illness than other groups of people, particularly black men, being probably the highest as far as being diagnosed with PTSD than women. I mean, there are illnesses that, you know, they could be equally the same, and in some of them it's majority women or some that are majority men. But in this situation, you're gonna find more African American men that are diagnosed, and particularly most of them are overwhelmingly it's military related for the most part, most of the time. And
And
also,
okay,
go ahead. I'm
so
sorry.
I was
Also,
going.
go ahead. I'm sorry. Go ahead.
No, go ahead and finish your thought on that, and then I'll follow up with a question.
Oh, what I was going to say is, and for those that want to clarify numbers, you can go to um, the American Psychological Association (APA). You can also look at um, um, the MH, the National Mental Health Substance Abuse Association talks about this. You can also um, look at any publication. You can even find this on Psychology Today. Of those that read Psychology Today, you're gonna find similar statistics. Again, everybody's not going to quote the same, but they're usually around a certain range. So you can. I'm just using that as a point of reference, where you can find mental health statistics on post traumatic stress disorder. That's why I just wanted to make people aware of reference points that they can research to clarify what I'm saying. The fact sheet per se. Hello.
Okay, yes.
Okay.
My question was, as far as the statistics, what would you attribute to the demographic being higher for the black male?
The reason why it's higher for the black male is because the black community has a large percentage of African Americans that live in hostile environments, particularly in urban centers, where there's going to be, and because of systematic racism, I don't want to get into all of that, but because of how black men are perceived and so forth, we get hostile reactions to things. I'm talking about police brutality. I'm talking about the prison industrial complex. The military is a lot of percentage of black males in the military that end up getting post-traumatic stress disorder. So, and then criminality. There's a lot of black men who develop post-traumatic stress from prison and involved in criminal vices and so on. Those type of behaviors, gunshot, glorification of certain things and being involved in that, yields those type of diagnoses if they have experienced that.
Okay, and can this lie dormant in anyone for years without them even knowing, or it being brushed off as anxiety, or what people would say in the old days, if you will, oh, my nerves are bothering me?
Right. Okay. So what we got to understand, PTSD is not an hereditary illness, meaning that, like, say, depression can be hereditary, schizophrenia can be hereditary, bipolar. This is a disorder in which there has to be an activating event, meaning there has to be a traumatic event that you witness or experience to trigger it. It has to be triggered in that. And there are people who go through traumatic events and they don't have PTSD. They come out fine, but many don't. And so it's highly unlikely that, I'm not going to say it's impossible, but it's highly unlikely if someone has post-traumatic stress disorder, it lays dormant for years. And if you look at the DSM criteria, it focuses on when the event or the traumatic event happens, you're having symptoms for at least of 6 months to a year or over consistently. So you have to, it's usually an immediate response. It's not a repressed response. If a person has some level of anxiety, and matter of fact, I'm glad you used that as an example because it kind of goes to something else. There are people, have you ever heard of defensive mechanisms?
Absolutely, yes.
Okay, so what you just talked about is actually an example of a defense mechanism such as repression, in which someone experiences something and they hold on to it for years before they actually let it out. So that's actually that's a different issue. Now, it does have anxiety related issues, but looking at it from a diagnostic standpoint, it wouldn't be PTSD. It would be some other illness that ran comorbid with you holding on to those situations for years before it actually before the actual event uh, was able to be recalled, and now you're suffering mental health issues because of that. That's and we got to also understand the brain is a very complex instrument, and for a lot of people who undergo trauma, there is a healthy percentage of people who have trauma who repress that trauma subconsciously and not even know it, or unconsciously. They just forgot about it, and they may have a dream or an event may trigger it where they start remembering these things. And so, but it would not be classified as PTSD. It would be some other issues that may be involved in that.
Okay, we spoke briefly, but I'm going to go over this again as far as treatment options. And here's a small list, and you can expound on each. The first one, and I'll repeat them, is therapy, then medication,
Mm-hmm.
pharmaceuticals, holistic, and yoga. So the first one is therapy.
Okay. When we're talking about therapy, um, I'm going to talk about cognitive behavioral therapy. We're going to talk about dialectic behavioral therapy, which is actually a form of cognitive behavioral therapy, but it's been very popular over the last 10 to 15 years. And DBA mostly focus on the regulation of emotions and feelings and anxiety. And then also there's another one that's called EMDR, and that's called eye movement desensitization response. And so in MDR, which I'm not an expert in that one. I've never trained in that one, but I know that there are therapists that use EDMR. Um, I'm sorry, EMDR per se. But it involves dealing with trauma or stress through eye movements, through your eye movements being the means of alleviating that stress or that trauma or whatever unwanted experience that you had, you coping with that. So those are to me the popular, most effective means of treating it. When we're looking at more of the alternative holistic means, yes, we're looking at yoga, meditation, things of that sort that involve, breathing, stretching your body in positions, instructional type stuff that you're doing to relax. Those things are used in conjunction with therapy. And as I stated earlier, I encourage people to use holistic forms of different types of therapy and activities that can also accompany or supplement the therapy. When we're talking about cognitive behavioral therapy, we're talking about the fact that we are cognitively looking at processing irrational thoughts and beliefs and responses to basically what is really happening and what's really going on. A person that has post-traumatic stress is in fear of events that rationally do not produce the outcome of the activating event. So just because you're around a bunch of, let's say you're in Vietnam, you're afraid of Asian people, rationally and logically speaking, those Asian people were not in that war. They were not going to harm you, but because you still have an imprint of that, it produces an irrational fear and an irrational response. So in cognitive behavioral therapy, we begin to departmentalize and assess and evaluate that thought process to restructure those thoughts through what we call cognitive restructuring techniques so that we can change your beliefs and thoughts and reactions to that stimuli. So I kind of highlighted all of those things. There are other, people use other things, um, you know, uh, as far as activities, but the most popular, most effectiveness, we're talking about MDR. We're talking about cognitive behavioral dialectic behavioral therapy. We're talking about, therapeutic activities such as meditation and yoga, Pilates, things of that sort. All of those things can be beneficial um, in managing PTSD.
Okay, that's excellent. Um, with your clients and your experience, how is it that you, and this is you as a licensed clinician, how do you deal with negative feedback?
From clients or from people, period?
Both.
Okay, from clients. Um, as far as negative feedback, um, usually I've never really had negative feedback as it involves the therapy. It usually had something to do with the business aspects of things. Um, such as something with the problems with the insurance, issues with scheduling, something going on with billing or stuff like it. I've never really had um, as far as complaints, as far as me facilitating the therapy. It's usually been over some other outside issues as it involves my business, the staff, things as far as the therapy session started late, or I was doing something, or let's say I was interrupted because of something going on and, during therapy, stuff like that. Those are usually the things that, I dealt with. But when those things do happen, we do process that, and I take in what the client says, and I immediately correct those things. Now, as it involves other people, um, I'm gonna just be honest with you. I have never received the level of pushback um, that consists of me educating people as I have on YouTube. Um, I never experienced anything like this. I really, be honest with you, I don't really get that much pushback. The only time I get pushback is from people on YouTube, and I'm just being honest.
And I'm glad you mentioned that. Yes, because I wanted to segue in, and this is professionally as well. And this goes for anybody, but especially because I've seen it firsthand for many different people. But when people question your credentials, or they may respond negatively in that they may not receive the response that you provide, or maybe in the way that they possibly expect. I have a family member that does this all the time with their primary care physician. Every time they leave, that person is a quack. They don't know what they're doing. And I'm saying to myself, everybody can't be wrong. So how do you do that?
Mm-hmm. Right. So you say how would I do what?
How would you answer any negativity that you just mentioned earlier? You only get it on YouTube.
Basically, to be honest with you, I just reflect on the fact that it's a reason why I am successful in doing what I'm doing, and I didn't come to YouTube to get validation from YouTube. I mean, my validation comes from the real world. And I just basically explained that if you have issues with me, if you have issues in regards to what I say, show me where I'm wrong. Show me what I'm doing is not consistent with the field. So I basically use the strategy of, if I'm so out of bounds, please show me anything textbook wise from my governing body, from my license. Where am I doing something that deviates from the truth? And if you can do that, you have a point. But until you're able to point out that I'm deviating from the field, then your claim has no basis. So that's the position that I come from. You know, if you just want to, you know, because you also got to understand, people that don't like you just not gonna like you no matter what you say. So for you to just say I'm not a good therapist, or you're not really a therapist, or you're a bad therapist, based on what? You have to show me and identify examples of me not saying something or doing something that's not consistent with the field. And nobody can do that because it never happened. So that's the basis. So if you're gonna have an issue, please point out to me the issue, and it has to be a legitimate issue, not something because I don't like the way you said this, or you said I don't agree with this. I'm like, it's not up for you to agree. If I am giving you a clinical perspective, it's based on a clinical perspective. There's no one way to do things to treat people. There are therapists who treat their clients totally different than I do, based on a different school or a different theoretical standpoint. But let's keep in mind, all therapies that use have a research base to demonstrate or illustrate its effectiveness. So when somebody's using a therapy, a bona fide therapy, it's not based because they just want to. There's data to prove the effectiveness of that treatment. You know, I'm not just using therapy because I want to. I'm using it because it has shown to be beneficial. It's shown to have been effective. So that's how. And I don't know how much of the videos and content you watched of me, but even when you saw me on Kwame Brown's channel, there were people, even though most of the people are like what I was saying, there were a couple of guys, I didn't even realize this. Some people told me there are people that was a guy I know for a fact criticized what I said based on me not having over 10,000 subscribers or something. They use subscribers as a means of me not being legitimate. And I thought that was funny. I like, subscribers has nothing to do with you being an effective therapist, but I get, you got to understand the environment you're dealing with. So you're going to have people say that kind of stuff, and some things are not worth responding to.
Absolutely. And we both know that the not the enter, but the internet is undefeated. So
Yes.
you have to consider your source, but I just wanted to get your feeling on that, because you're absolutely right. You can show your credentials and your resume, but there's always going to be one or two that may not like the way you deliver, if you will, your message or your assessment, and just run with it.
Right. And my thing is that I understand that my position is that is a risk of when you are on YouTube, and I understand that. I understand the risks that are taken when you put yourself out there. Those are the things that could potentially happen. Hey, I take it in for what it is, but I as far as me being concerned or overly concerned by those opinions, again, I have years of experience to to showcase what I've done. YouTube is not any type of social media will not make or break me. I could decide to get out of YouTube tomorrow, and my life doesn't change. It's going to be as it is now. So I try to get people to understand that your opinions, even though you have a right to that opinion, if you can't criticize me without basis, without proof, without legitimate reasons in which I'm doing things that are inconsistent to the field, then it's just basically you having an opinion that doesn't mean anything. That's just how I don't even respond to some stuff like that because I know they understand what they're talking about. So but I've gotten all types of criticism about things, and it's okay. I actually laugh at it. I think it's funny, but it is what it is.
Okay. Well, moving on, we have, now that everyone is clear, moving on, we have a comment. And it's from Miss Andrea, who says, I've learned a lot of defensive, I'm going to assume she means defensive mechanisms, seen overwhelming things growing up that I blocked out mentally. And she adds, meds only stop brain from spinning like a merry-go-round.
She said, what stops your brain from spinning?
Meds only stop.
Oh.
Yes.
Well, I can't speak to how the meds affect you because I've never been on any meds, or the fact of the matter, I have clients that all have different responses to the medication. So that response is only relative to her individual experience. It's different for other people. So I'm not discounting it, but I'm just letting her know that other people may have other responses, or they may have other positive responses. So,
okay. Next question, and this is not to offend anyone, but this is again something that needs to be discussed. It may be considered the elephant in the room, but again, it needs to be discussed. And if you're ready,
I'm ready.
Can people feign or fake PTSD for personal gain? And the reason why I ask this is strictly due to my involvement in working in investigations at the VA in particular, where we investigate so many fraud cases in reference to PTSD, because in order to get 100% service-connected disability, you must have a stressor letter, and that stressor letter must be written and delivered in a certain way. And you would not believe, well, no, you probably would.
Well, I know people that
many different doctors who have been paid an exorbitant amount of money just by writing these letters alone. And I will mute my mic on that one.
Okay. I'm glad you brought this up.
Yes,
because this happens, and I'm going to say this, unfortunately, this is the dark side of mental health. This happens a lot more than what people think. And as an investigator, I know you've seen things, but I'm going to let you know that a lot of psychologists, particularly those that do those evaluations, you ever heard the term malingering? The malingering client, or malingering actually was a disorder. You ever heard of malingering?
Yes.
Okay, that's basically a person who intentionally fakes like they have a mental illness, and they repetitively do it. Now, some can do it and that just not be controlled. They're just constantly faking and acting like they have this or that, and so on. Matter of fact, there's a person right now that I'm no longer friends with on YouTube because of jumping from one disorder to another. And the first disorder, if they had the disorder, they would have actually identified the new disorder that she claims she has. And so I actually lost a YouTube friend behind her changing her diagnosis when The new diagnosis would have been picked up the initial time. So I had to. I don't want to get out, but I'm glad you brought this up, and I want to talk about this. Um, Unfortunately, in this field, there are going to be mental health professionals who are money hungry and who are willing to do favors for financial gain. Most mental health, most mental health um, professionals are not willing to do that, but there are some that are. There's enough that who are willing to write up reports, who are willing to give diagnoses to help someone out, friend or somebody, or someone that they just have an affinity for. This does happen. We're not going to pretend that these type of things don't happen, because they do. And there are fraud cases. Now, I know I can identify a malingerer, somebody who's faking. Okay. And one of the ways that I can identify that somebody's faking is that the over dramatizing of the symptoms. Because a person who really has that, they don't have to dramatize the symptoms. They can just be who they are within that baseline, and you'll know. But I'm talking saying all kinds of off the wall stuff that's just overly. Matter of fact, I've had situations where parents have coached children to doing this, and I've even had adults saying things and doing things to try to get a diagnosis so that they can get benefits or get approved to go do this and do that. And so for many, particularly psychologists that I've worked under, they don't bother with it. What they'll do is just document what they document and go through the motions and write the report and be done with it. They don't want to get into the means, because the reason why they don't want to get into assessing whether they're malingering, because it's going to require more time and more tests. And they don't want to do that. It requires more work. So what they'll do is they'll take what you say at face value, would not care, write the report up, and be done with it. And so most of those guys that get away with that, they probably dealt with a therapist or a psychologist who did not want to bother with assessing those issues. They just wanted to just go through the process, complete the 3 to 4 or 5 hour assessment, and move on. So it does happen. I notice it when people over dramatizing their behavior, coming there dressing crazy and saying all kinds of crazy stuff, off the wall things that are not necessarily consistent with the illness, but they're trying to play mentally ill just on the basis of playing mentally ill. And so you can pick it up. I can pick it up. I can tell when somebody's I'm not saying I'm 100% great at it, but I can, for the most part, pick up when somebody's, being a little bit too theatrical to make that point to pass an exam or so that you can okay their illness.
Absolutely. And I think a lot of people don't understand. And again, I don't mean to be an elephant in the room, but this is something, again, that needs to be discussed. And it does not apply to everyone. So I will put this disclaimer out. If it does not apply, let it fly. But I know from experience, this is in the black market, if you will. And I don't mean that as a race, because this is not race specific. Let me be clear, nor gender specific. There is a lot of money in these type of cases because, number one, 100% service-connected disability, that at that time was almost $4 or $5 grand non-taxable funds at that time.
Thanks.
So you get that check, you split it with the doctor that has written this stressor letter. Can you imagine the amount of money that these doctors made? And what made this particular doctor and this particular case is I mean, people for some reason think that when they're doing something illegal, that they'll never get caught. Now, I always said the wheels of justice may turn slow, but they turn. And in some cases, things take time and you watch them after a while. And those that actually review claims, there's a certain way the claims are set up. And again, the stressor letter is key, and there's certain languages that need to be used. It was brought to one of the agents, and upon reviewing I'm going to say at that time maybe 5 files, they noticed that the stressor letter was signed by the same doctor in each case. So upon further investigation, by the time it was all over, it was 20 benefit cases where the stressor letter was signed by the same doctor. So they started to investigate him,
Wow.
his bank account, and needless to say, all of those claimants had to go to a VA doctor to get a stressor letter. And I think out of all of them, maybe 3 were actually approved.
Wow.
So
yeah, that's the dark side of mental health.
Very.
Dark side of mental. It goes on. I've seen it happen with Social Security benefits. I've seen it happen with people trying to, doing it in order to qualify for housing or something, some type of government benefit, or for the children. I've seen it. I've never partaken in anything, but I've seen it happen. I actually, one time, I never forget, this was back in 2000, I want to say 2010, 12 years ago. There was a Hispanic kid that came. I think that the parent and the mother was trying to get him benefits. And he literally was just saying all kinds of off the wall stuff that made no sense. And the way he was doing it, I could tell he was just intentionally just blurting out stuff out. And I told this to the doctor, and the doctor was like, "Don't worry about it. Just document what they say. Let's get it over with. We'll do the." And I'm like, "Okay, if that's what you want, that's what I'll do." But this happens. It happens.
It most certainly does. And the thing is, I don't think a lot of people understand that even if you are approved and it is later found out that it was approved due to fraud, those monies that you receive can be recouped. Or you
they're gonna want that money back. They want all that money back. Yep.
Yes, you may be ordered to pay not only a fine if it's prosecuted, but also restitution.
Yes.
Total restitution.
That's right. That's right. And that can happen. So I just want to, hey, that these things can and will happen. And so we just gotta, it to me, this goes on so much. It's really difficult to supervise and manage. And so the only thing you can do is just, try to catch the ones you can catch. But it's going to be a lot more to get away than those that you catch. So that's all. That's basically all you can do. You're pretty much at the hands of whatever amount of resources you have to do it. So. But I will say it does exist, and people faking and mental illness. And I've even heard people doing it in hospitals to try to get off of reduced prison sentences and stuff like that, so they don't go to jail. Psychologists talk about observing the consistency of someone keeping up the faking it for a long period of time. before there's usually a cutoff time where the person stop, you know, faking and start being themselves after about 3 to 6 months. But it happens.
Absolutely, and that's the purpose of actually following people. Again, they will. I've seen where we actually follow people to a facility. They would get out their vehicle with their cane and the walk, if you will, that they're in pain. They get back in the car the same way. But once they get back to their residence, that cane is in the cart, and that walk, which was hobbled, is now straight.
Wow.
Yes, so I mean it's prevalent and it's unfortunate because there are so many people that have to wait so very long for their claims to be actually not only just processed but finally approved. And I'm talking about some people have to wait for years, and it's not fair because there are so many that have lost so much, to include families. And that's something else I wanted to bring up. Those nuclear families, the husband, the wife, the children, and the dog. How does one live, or how would you or should you show that you care, or is there anything that you can do to help ease these symptoms when someone is having an attack who has PTSD? Like I said, as a spouse, or maybe even as a child or a young adult that's living in a home.
So, as a family, I want you to understand it is not difficult living with someone who has PTSD. Um, a lot of situations, parents get very, or kids, or particularly if it's a parent that has it, um, it can overwhelm and drain out. It could become emotionally draining, particularly if the person who has the illness is not getting help. What I encourage the family to do is to support the identified client and to learn aspects of the illness so that they can understand how to function with that person. Unfortunately, in many situations, many people who have PTSD that are in families, they're not enjoyable to be around. They A lot of situations that I have, particularly doing family therapy, uh, the, even the client admit that they're horrible to everybody around them. The family, the kids, the wife. Some it can go into abuse. There's usually there's a lot of irreparable damage at some point for some of them where it causes divorces. But in a lot of cases, there's usually not a favorable outcome. But what I can say is that treatment is important. If the family is going to sustain itself, treatment is important, and also the um, participation of the family in therapy can increase the chances of helping that client learn to function with their illness. So that's usually what happens in many situations. It's about the treatment and the family being involved in the treatment.
Okay, I had a question. Um,
Sure.
how long, in your opinion, your perspective, is treatment? Can it be short term or for the rest of a person's life? And I'll explain the reason why I asked that in a real life situation upon your completion of the answer.
Okay. Well, it can be either or. I mean, there's some people who have post traumatic stress that are able to function with and without medicine. Then they have those that function with therapy or medicine on a monthly basis. I mean, I have a PTS client I see once a month. They're highly functional. They don't have any issues, but they like to have therapy for maintenance purposes. And then you have those that they haven't had it in years. They hadn't had episodes, and they move on with their life. A very small, I'm gonna say less than 5% are able to live the rest of their life without having an episode. The overwhelming majority are going to need some type of intervention, whether it's by medicine or by counseling. It could be at a reduced level, but if whether it's once every month, once every other month, usually most like to do for maintenance level once a month or on an as needed basis. So it varies, but there is possible there are, a small percentage who won't need therapy or any type of intervention. They went through the treatment for a year or so, and they're good after that. They don't have another situation. They're no longer affected. But that's a very small, minute number. That's that. I don't expect that very often. Um, when it involves a um, diagnosis like PTSD.
Okay. A person that's very close to me. How can I put this? He, I call him my gentle giant. Very supportive, always has been. But I do know that there's PTSD there, but it's what you call functional, if that's
Yeah,
the correct term.
yeah, that's
Um,
functional PTSD.
and one of the mechanisms that he uses outside of his job is being a crime advocate, helping victims of other crime. So I think that is how he, I'm not going to say treats, but offsets some of the symptoms that he may experience. There are some things, and there are some days that I know he hasn't been able to go to meetings, and he's also mentioned that he didn't know how long he'd be able to continue it. So I'm wondering, is it beginning to be a stressor? And the reason why I say this is because he witnessed his spouse being murdered by a stalker, and then a portion of his arm blown off.
Oh wow,
Yes,
that's
yeah,
difficult.
very difficult.
Um, that's difficult. I'm going to say because of the fact that that was his wife and the fact that he has to live with the fact that he's disabled because of that, it's highly unlikely um, that he is going to be released of that issue at some point. He has to live with that for the rest of his life. I think it may be important for him to realize that hey, this is something, at least minimal maintenance reasons. The fact that you had part of your arm blown off and then you lost your wife, that's something you don't forget. Or I mean, you can heal from it, but it's going to have an effect at some point. There's going to be a point where that affects you. It's highly unlikely that that person can go the rest of their life without needing therapy, not with that severe of a situation that occurred. I mean, but I'm not saying it's impossible, but it's highly unlikely.
Absolutely. I mean, and I can tell when something is bothering him. So I try not to bring my issues because, I mean, being in our fields is already difficult enough. So I was just wondering about that. And then with the holidays coming up, and that's what I wanted to elaborate on as well, as far as demographics and statistics. I know for sure that even with some treatment, that there are veterans there are people in law enforcement, especially first responders that unfortunately, and again, this may be difficult to listen to, but it is what I know to be as truth, actually take their own lives despite
Yes.
treatments and therapies. And I'll mute my mic.
So it's funny that I'm glad that you brought that up in regards to the fatality rate or suicide rate. There is a high suicide attempt and suicide rate amongst veterans. Now, it's higher among veterans research wise as outside of other groups who develop it, because the majority of PTSD, as I alluded to earlier, is usually going to be veterans or people who are in some type of criminal justice department field, in the criminal justice field, law field, and things of that sort, or any combat related industry. Unfortunately, there are certain periods of times where suicides rise, and unfortunately, the holidays is when we approach that end of October, November, December 8 up to the beginning of the year. Suicide rates do increase, and also suicide rates consistently increase around the springtime, around April, May, around school graduations and college graduations, things of that sort. And that's actually, to me, the busiest times of the year. It gets real busy right before school. It gets busy. I mean, people try to take off or whatever, but it's like that early part of January, after the aftermath of people being stressed out during the holidays. It also creates another influx of people wanting therapy, or people and I commend people who can't cope with issues of death and dying and stress related events because of trying to uphold Christmas traditions and Thanksgiving traditions. They can't afford it. They're financially stressed. People who go through PTSD, they can have a high level of suicide ideology and attempts, hospitalizations. There's a high risk of that. And during those holiday times, again, as I talked about, the holidays like now, or any holiday throughout the year, or any symbolic period of time in their life, that puts a person at risk who is unable to cope. So research does show, like I said, as far as the research, I would say military personnel are usually the higher risk of that than other demographics. But the research shows that there is an increase of those attempts. I'm not gonna necessarily say those who actually become successful, but the number that you really got to look at is the attempts, because that shows the risk. Because usually a person who attempts suicide, they didn't do it out of impulse. They probably thought about committing suicide 3 to 6 months before they actually engaged in it. It's just that day was probably the day they just decided to go through it. So that's typically what the research states. As far as an overwhelming majority of them are military related, and during that period of time from around end of October, November, December to early January, those are usually high points for that type of activity occurring.
Okay, well, annually we know that Veterans Day falls on the 11th, and it's observed to pay homage and tribute to the men and women of the armed forces. Do you have clients that welcome that day, or that is a trigger to them from your perspective?
I'm gonna be honest. Most of my clients really care less about those military. Actually, most of them are actually disgusted with the military. they don't care about. They just want to move on. Once they get out the military, they're just ready to move on. Matter of fact, there are situations in which a lot of clients complain about the military itself, that were outside, particularly the women. There are a lot of women who experience post traumatic stress due to their treatment as women, discrimination, sexual assault. There's a dark side of the military when there's there are events of sexual assault, rape. I'm sorry, things of that happen, abuse that goes on that doesn't get resolved. And I know for a fact, particularly women that are in the military, they are apathetic. Once they get out, they don't want to have anything. And some of the guys too, they actually have complaints about the military. They have discharges, whether it's honorable or dishonorable. They just wanted to just move on. They care less about continuing or celebrating their military achievements. They just want to move on in life. Now, that could be different for somebody else, but very few veterans that I know, they treasure the holidays and things. And now, they want to be recognized at some point. But as far as carrying on that and things of that sort, they want to just move on with their life and not even, discuss those things. Again, that may not be relative of others, but that's what I've encountered.
And is it wrong for someone to want to be recognized for their service? And that
No,
goes for any profession.
they should be. They should be recognized. But my biggest issue with the military, as I've learned more about the inner workings dealing with this demographic, is that there's a lot of things. There's a lot of ineptitude in the military when it comes to like people getting benefits. And I mean, there's so many. Some people, guys will complain about stuff with the education getting paid for. The military, the VA system has been much maligned before it kind of changed a lot of things over the last 5 years. They had scandal in itself about only dealing with certain providers. That quickly got alleviated, and that no longer exists for the most part. And it's been pretty open to do VA stuff, VA related work. But I'm going to say less than 50% of my clientele is happy with the military. Most of them are not. I'm going to say over 60% are not. Less than 40% are happy, and but everybody wants to be, they want to be validated. They want to feel appreciated. But there's issues that occur that make that a problem. So I also want to say, I can take maybe a couple more questions, and I do have to call it a day because it's getting about that time for me. But I can take a couple more questions.
Not a problem. If there's anyone in the chat that has any questions or would like to speak really quickly, the link is there. And thank you so much, Mr. D. Derell, for this enlightening and important subject. So I'll wait to see if anyone would like to take the link and ask a couple of brief questions, and we'll close this out. So let me put this on mute and see if anyone comes up. If not, then again, this has been extremely informative and much needed.
Thank you.
And I will make sure that I replay this again for those who did not get the opportunity to join in earlier. I know there were questions earlier. Maybe they'll leave them in the comments. And is there anything that you wanted to add as far as any projects or things that you're working on?
Well, it's funny that we talked about the military because I don't know, because a lot of military are in TRICARE and military, they have the military. So I actually just received, I had some issues administrative wise with the VA. And I was actually getting a plethora of VA clients from the Dallas area that I was seeing virtually. And so I just actually got approved for a couple of contracts about 3 days ago. So I'm actually going to start getting an influx of new VA clients from a different, I guess, type of military insurance. So I just learned about that. So because I haven't seen a VA client probably since um June, since June of this year, and I didn't know that insurances highly affect how you do treatment, and I didn't know that they were connected to Blue Cross Blue Shield, and I had an issue with Blue Cross that kind of spilled over to the VA as far as paperwork. But I am being that we are talking about this, it kind of makes me look forward to getting back into getting those type of clients again, which I'm probably in the next 3 4 weeks they'll start giving me referrals. So I'm actually looking forward to engaging back with those type of issues and dealing with that demographic of client. But other than that, it was wonderful. I love the questions that you gave me. They were highly stimulating, and they were highly uh, related to what I deal with on a day to day basis. So that was good. I do appreciate the questions.
You are very welcome. Well, I don't see anyone that has come up with the link, but again, they're welcome to leave any comments and I can shoot those to you at a later time. But again, thank you so very much, and hopefully, we all can see you again. Um,
Oh, definitely.
if there are no closing remarks from anyone in the chat, and if you don't have anything else, again, thank you so much, Mr. D. Derell. I have posted your link in the chat, and I will do it again. You enjoy the remainder of your Thursday, and hopefully, this has made some people a little bit more clear on what PTSD is, the demographics, which again, startling to me, but a well needed conversation and really needs to be more of these. But with that, I will let you go. And again, enjoy your evening and thank
It was
you.
a quick game, though. We were not there for.
All right. You have a great day.
You too. Thank you. Thank you, everyone who joined. Felice K, Carl Belton, Andrea Smith, Amelia Dixon, Babe Girl, Thug Life Manning, Miss Eugenia Brown, Be More Legend, Felice K, Miss Shirley Kirkland, Mr. Exodore Hammond, Sam D, POB, Monica Collins, Jade Lee, Andrea Smith, Miss DL, Mr. Trayron or Carla. Thank you all very much for attending this broadcast, and thank you to those from Facebook. Please make sure, if you haven't, to hit that like button before you leave out the door, and subscribe, and most importantly, share this very important video. Also, make sure you head on over and subscribe to Mr. D. Derell. Again, thank you to everyone. Oh, thank you, Miss Andrea, and thank you so much for participating. Hopefully everything was answered for you. If you have anything else, please be sure to leave a comment, and we can revisit this again. I will be doing a replay for those who weren't able to attend or comment. But again, Thank you, everyone. Be safe, be well, and you know the rest. Be healthier. Until next time, take care.